Hi, everyone. Thank you for having me here. My name is Pablo. I'm an anesthetic trainee and a pain fellow in South London. And it's an honor for me today to be presenting Needles in a Haystack, my review of top papers for phantom limb pain of 2025. And also a big thank you to Dr. Kroll, my mentor, who has been supporting this project. Phantom limb pain remains relevant in 2025 because it's the invisible epidemic. Literature tells us that it has an extremely high prevalence. In some cohorts, up to 90% of the amputees suffer it. It's chronic, intractable, and there's no right way to treat it. There's no standard. However, it does have a major impact in quality of life. You're taking previously functional members of society that go through a traumatic event and may never go back to their baseline, which is a huge toll in their mental health, and eventually it also becomes a healthcare burden. However, 2025 did deliver some new and interesting progress. The first paper that I bring today is the relationship between neuromodulation, pain, and depression in patients with phantom limb pain. And it's a systematic review and meta-analysis where they analyzed and identified 56 papers out of all of the literature and kept 17 RCTs with the inclusion criteria of RCTs, adults, and phantom limb pain in the non-acute phase, a total of 510 patients. And they divided neuromodulation into two groups: central, that had 10 RCTs, and peripheral, that had 7. More interestingly, only 2 for peripheral nerve stimulators. And they looked at 2 primary outcomes: pain, all 17 RCTs looked at that, and depression, only 3 of them looked at that, and they were mainly about central neuromodulation. And what they found was causation, a significant pain reduction in patients that underwent neuromodulation versus control. And they understood clinically meaningful effect as a reduction in the VAS score below 1.4 points. Overall, neuromodulation reduced VAS score by 1.6. Central neuromodulation, mainly stimulating area M1 of the brain, reduced in TMS by 1.4, direct current stimulation by 1.6. And in peripheral neuromodulation, PNS had a great effect, nearly 1.9. On the contrary, TENS was just about 0.46, not clinically meaningful. And furthermore, they found no relationship between depression and central neuromodulation. So this study has some interesting strengths. It's a multi-technique comparison. Sensitivity analysis suggests a robust pain signal reduction. However, there are limitations. These RCTs tend to be small and heterogeneous, and they only focus on the short-term data. However, there's no standard of delivering this modulation. Parameters and targets are all over the place, which makes it very difficult to replicate their results. So in conclusion, dose and duration matter. And we see this mainly in central neuromodulation, where the bigger the frequency and the more regular the sessions, the bigger reduction in VAS score. However, there's no standard, as we mentioned. So everyone does a different technique. Peripheral neuromodulation, mainly PNS, seems to be more effective. However, there were only 2 RCTs identified, despite a growing body of observational studies. There's no clear effect on depression. There's no clear strong evidence for invasive modes yet, such as SCS. So we've seen that neuromodulation can reduce the intensity of phantom limb pain. But this is when phantom limb pain has already appeared. What can we as anesthetists do to prevent this from happening? Can we stop the appearance of phantom limb pain? And it seems that the answer may be yes. In our center, we've been inserting perineural catheters for more than 20 years, working behind the hypothesis of the amputation happens, a perineural catheter is inserted at the end of the procedure with the intent of reducing the acute pain after the surgery, therefore potentially reducing the central sensitization in hopes of reducing phantom limb pain. And there's a growing body of evidence, mainly observational studies, case reports, cohort studies, but there are very few RCTs. And in 2025, they analyzed the effectiveness of this. They created a systematic review where they identified 357 studies, but in the end, only included one RCT in evidence synthesis. In this study, they had 144 patients and they left the perineural catheter for 6 days. And what they saw at 4 weeks was a significant reduction in phantom limb pain intensity. The mean pain reduction was around 1.5 points in NRS scale. And also, it went hand by hand with an improvement in the functional impairment. Authors classified this evidence certainty as moderate because it's a single study. So in conclusion, perineural catheters are a potential therapeutic option for phantom limb pain. Current evidence, however, is limited but supportive because, as we've just seen, there's only one RCT looking at this. But there's, as I mentioned, a growing body of evidence of cohort and observational studies supporting this practice. And as I said, we've been doing this for 20 years in our center. It is our standard of care, and we normally audit our findings and our results regularly. And this year, in 2025, we published an abstract of our audit where we did a retrospective observational audit of 40 below knee amputation patients that had their operation 2 years before. So addressing the gap of knowledge of short-term outcomes, looking at long-term outcomes. These patients had had their catheter left in for 7 days with a continuing infusion of local anesthetic, and we surveyed their pain at 2 years and also their quality of life. And with the results, we saw that, unfortunately, around 30% of this population had passed away. This goes in line with what literature tells us to expect. And out of those survivors, more than 50% agreed to participate. And the results were interesting. Around 90%, so 14 out of the 16 patients, had no phantom limb pain. What they did complain about was about stump pain, and this was around 50% of the population. And when they complained about their stump pain, was due to the prosthesis use or that the fit wasn't good enough. And those that complained about phantom limb pain, so 2 out of 16, they said that it wasn't quality of life limiting. Therefore, it could be classified as phantom limb sensation. More interestingly, there was an 85% reduction of analgesia requirements down to first step of WHO pain ladder even. And obviously, there are limitations. It's a small sample size. It's not an RCT. There's no control group. But because it's also standard of care at our center, it's a retrospective design, and we lost some patients to follow up. However, it does add as I mentioned, to the conversation. It does add evidence to this growing body that we said. So what does 2026 have for us for phantom limb pain? There are very exciting RCTs going on. However, 2025 gave us a glimpse of what may be coming. We saw a prospective pilot case series of a new device. And as anesthetists, we love new devices that can deliver a single shot block, a continuous infusion, and can modulate the nerve at the same time. And this was in an acute pain setting, looking at ambulatory care in moderate to severely painful surgeries. These catheters stayed in for 7 days and went with the patient home. The main focus wasn't an efficacy trial. It was a feasibility and safety trial. However, what they found was that the average pain for 7 days was 2 in NRS scale. And the worst pain was less than 5 after the first day in most patients. And the average of oxycodone use for the whole week was around 43 milligrams. And it has limitations. No control arm. We don't know what's working. Is it the local anesthetic? Is it the neuromodulation? However, the take-home message here is that it is promising new pain technology that is coming. And it also potentially, it could open new possibilities to all these conditions that we know that in a chronic setting, we can modulate them, we can prevent it. And for those conditions that are in an acute setting and can chronify. So overall, 2025 has left us with some answers. Phantom limb pain may be preventable and treatable, but we as an anesthetist have a key role in this, and it starts at the very beginning in the OR for us. We can start very simple. We can try and avoid it from happening. Think about regional anesthetic. Think about using a perineural local anesthetic catheter. The evidence, slowly growing, is there. And when it happens, we know that neuromodulation is a proven non-invasive control option for phantom limb pain. And lastly, new technology may open new frontiers in 2026. Thank you, and happy World Regional Anesthesia and Pain Medicine Day.